So I invite Alejandra, not John. Is that right?
No, you invite John.
No.
John speaks. I mean, this is amongst us. The speakers,
Okay.
Alejandra will take forward
Okay, perfect.
after John speaks.
And for all the speakers, and I'm sure all of you have been here multiple times, if there are any questions or answers, because we have younger people here who would be presenting the cases, please look into Q&A and answer your type your answers in real time, because we are not able to take up each and every question at the end of this. So please keep on typing the queries at the end.
Okay. Yeah.
So the one thing I just saw this was good, that virtual background for all of us already gone.
That's right.
So we don't have to struggle to adjust it.
Yeah,
That was
very
a
nice.
new one. Hello, Dr. Ratinam. Hi, Masimo. And time to start.
Hello everyone.
Hi, everybody.
Hello.
Hi.
Nice to meet you again.
Hi,
Nice to
Happy
meet you
New Year
all.
to everybody.
Yeah, nice to meet you
Happy
all.
New Year.
Happy New Year.
A
And
very
happy
good
Pongal.
evening. A very good evening to all of you, and a very happy New Year to you and your loved ones. Wishing you all a wonderful, wonderful 2024. So, as promised, IUSG education team led by John Campen, and with a very super solid support from all the members, especially Alejandra de la Torre and Rima Bansal, we have designed the uveitis grand routes. This is a kind of sequel to the didactic talks, which we have finished last year. And now is the time to come to the clinic and see, to apply that knowledge in the clinical practice. This is the first grand round that starts with anterior uveitis. So every time we will have a thematic lecture, followed by 3 case presentations by our younger colleagues, and each case will have a discussion by a senior colleague, and some time for controversies towards the end. As usual, we do have CME credit hours for this. You will receive an email after you complete the session, and you have to give your inputs, and the CME credit hours certificate will be emailed to you like previously. And all these grand rounds will be available on IUSG website in case you want to watch them later. We encourage you to type questions in Q&A, which we would try to address as soon as you type. With this, I will pass on the baton to John Kemper, who's the chair of Education Committee for IUSG, and he will take it forward. Thank you very much once again to everyone.
And thank you everyone for coming. The IUSG sort of realizes that excellent uveitis education is not available everywhere in the world, especially in sub-Saharan Africa where I'm working. It's just beginning to be introduced. And so this is part of a program of trying to help everyone to be well educated in dealing with the problems that we have as uveitis specialists and managing uveitis cases for those who aren't specialists. We can do so much for these patients, and so we just want to make available more opportunity for everyone to learn about how to take care of them. And so as Vishali, our president, was mentioning, this is a sort of case-based learning type of approach that we'll be doing monthly. And so it's a strong way of learning to manage things, and will systematically cover major kinds of uveitis over time. I'd just like to encourage everyone to invite your friends to attend. We'll be having it monthly, and you'll hear more about the next session at the end. And so thank you very much. Alejandra?
Thank you, John. Our thematic lecture is Rupesh Agrawal from Singapore. So the case discussion includes first Non-granulomatous anterior uveitis, presented by Miranda Guerci and discussed by Stefan Thoreau. Second, anterior uveitis with rise IOP, presented by Armin Kakabi, with Uwe Player from Germany leading the discussion. And then granulomatous uveitis, presented by Jonathan Malcolm Chavan and discussed by Dr. Ratinam from India. We'll wrap up with a 10 minutes general discussion. And thank you for joining us, and let's get started. Rupesh?
Okay. Are my slides visible? And am I audible?
Yes, Rupesh.
Okay, fantastic. Thank you, IUSG. Thank you, Dr. Alejandra, Dr. Rima, Dr. John, Dr. Vishali, for having me here for this webinar. Dear friends, I think you will be wondering why we kept this simple topic of anterior uveitis, but I'm sure those who practice uveitis will understand sometimes it is not so easy to manage anterior uveitis, and therefore you'll be thinking at the beginning of the year why we kept a straightforward topic of anterior uveitis. So in next 90 minutes or so, we'll be seeing what all we need to discuss about the anterior uveitis, but before that, we start with this 20 minutes of didactic lecture related to anterior uveitis. But I'm going to keep it a little bit different based on some of the thoughts which were gathered. And thanks to my fellow Carlos, who joined me a few months before, who helped me prepare the entire set of slides for me after discussion. Thank you. So the first slide which I wanted to present here is the vision by Professor James Rosenbaum, who wrote in his beautiful editorial about the coming years, how do we want to treat the uveitis. You have a slit lamp, you put the patient on the slit lamp, and slit lamp give you some kind of a biosensors and give you assessment of cytokines, giving you a very specific diagnosis, and will also prepare you with what medicine you want to give and probably use some of the novel techniques for drug delivery. So that's the future which we all want to kind of live in. And it is good to dream, good to keep this dream coming up. Then only we can move forward in this field of anterior uveitis. But going back to the school classroom, best is to understand why we want to treat uveitis and set up some goals and principles of management of patient with anterior uveitis. So the broad strokes, as we all understand, and those who are the new uveitis specialist or general ophthalmologist, is basically preservation of the function. That's the fundamental importance. Control of the activity in the terms of inflammation by reduction of inflammation and keeping the inflammation under suppression. Preventing the recurrences and prophylactic treatment to prevent future attacks from coming and preventing the complications. So I think all of you will agree that if we follow these broad principles, mostly we have covered everything. But however, the concept which we want to introduce and the concept which has been published in the literature is dynamic therapeutic objectives. So your goal might change as you progress further, and might be these broad principles will remain, but it has to be dynamic. You can't say that I have said this on the day one, this patient will receive 4 times a day, and you don't change it as you move forward. So this is one of my take-home messages for everyone listening to this talk. Your goals and the approach will be very, very dynamic as far as the management of uveitis is concerned. So I divided broadly this talk into 5 broad topics, as we said, at the 5 basic broad principles about management of anterior uveitis. So knowing about the epidemiology of anterior uveitis. So don't worry, this is not going to be a research topic. I'm going to keep it really practical. Second is about navigating the path to the precise diagnosis. Third is basic management of anterior uveitis. After that, if and when we need to start immunomodulatory therapy or particularly systemic therapy, and what do we do particularly in context of infectious uveitis. Now, the important topic is knowing the epidemiology. So we have global faculty here. We have from India, Europe, and even Latin America and US, the faculty who are here. But I'm sure all of them will agree with me that how uveitis can present broadly. And no one else better than John Kempen, who has worked a lot on the epidemiology of uveitis, he will agree that why such a papers are important. So one of the paper, which broadly says the systematic review about 9 to 730 cases per 100,000 individuals, and how much the incidence can change, where geographic region can play a significant factor in the way we see the uveitis. This is the first thing. Anterior uveitis has been reported across many different studies, in particularly more prevalent in the Western world with non-infectious causes. So this is again coming from the literature, coming from this epidemiological paper. So you need to know that even if you're practicing uveitis, then you will be aware about what's going to hit your clinic and which is the patient you're going to see. So it is absolutely important and paramount important that we should be aware about what's happening in the epidemiological trend as far as these uveitis entity is concerned. Once again, to look into different studies coming from different parts of the world, you can look into the study by none other than Professor Alexandra and the colleagues from Colombia. The etiological cause changed from infectious to non-infectious in the recently, and this article was published very recently in Graphes in 2023. And after that, in Italy also, there has been a change in trend from non-infectious to infectious. And again, in another study, though published a little bit earlier, there was a change in the pattern from non-infectious to infectious. So I think Dr. Ratinam, who is on this call as well, she will agree that the change in the pattern from non-infectious to infectious, because of our ability to pick up certain things, certain clinical signs and certain tests, which we are able to say that probably it's there. A recent article by one of my favorite fellows and Dr. Ratinam's fellow is published in Ocular Immunology Inflammation is on leptospiral uveitis. So I personally don't do leptospiral uveitis in a lot of cases, and we had a lot of WhatsApp exchange of messages about when should we do, and she published this about, and this is one of those underreported entity, and I'm sure we'll be hearing about this in coming IUSG webinars about this. So to come back to the point, knowing the distribution pattern and the changes with periodically over the time should be the objective of each and every region, particularly each societies in the region. And if possible, all the uveitis specialists, if they can educate all the other colleagues about how the things have been changing. And with the changing, we will be able to probably get the correct diagnosis and help our patient. So coming to the point number 2, how do we come to navigate or get a precise diagnosis in patients with anterior uveitis? So it is fundamentally important in the field of uveitis, which is very close to the field of medicine. So those who have loved medicine in their MBBS, they will understand how critical it is about history taking. So having a standardized uveitis questionnaire, which you repeat it again and again and again and again in your patient with the uveitis is fundamentally important. And each clinic can have their own set of questions which you are trying to put up. Sometimes it becomes very boring and why you are asking some of the questions. But I think if you follow this regular thing, probably you will not be missing some of the diagnosis. And therefore, the web platform which we published on OSS, Ocular Autoimmune Systemic Inflammatory Infectious Study, is just not about the research platform. Some people think it as a research platform, but this screenshot from the platform tells you about how you can have a very methodological approach towards a patient of uveitis so that you don't miss any of the clinical sign when you are evaluating a patient of the uveitis. You imagine a world where you are going to enter all these features and automatically based on AI algorithm which we're developing, you will get a diagnosis of the uveitis based on whether there was keratic precipitates, if those keratic precipitates were there, what were the type of keratic precipitates, anterior chamber cells were there or not, IOP. And once you put on everything there, automatically, whether it is based on the Sun classification or whether it is based on any other classification, the diagnosis came down at the bottom, and then that will be the guiding tool for you to approach your patient with a uveitis. So this is an attempt, but only it will come when you have a very methodological, a very systematic approach towards seeing a patient with uveitis. Recently, day before yesterday, even though as a senior uveitis specialist, I saw a patient, but I forgot to switch off the room light. And then my fellow reminded me, Dr. Pesh, you forget to switch off the light. But immediately I saw that picture I could not take. I could not see any flare or cells in the eye with the room light on. But when we switched off the light, then we were able to pick up very subtle cells which were there and almost 0.5 cells which were there, and we were able to see. So some of the fundamental importance which has been taught to us before the exams, when we go for the exams, we try to do that. I think it is again very, very important for all the uveitis specialists also to teach to their residents and other new uveitis specialists to follow these tricks and follow the simple principles of uveitis evaluation when you are seeing. So once again, I'm not going into the details of how the KPs looks like, what should be the KP pattern, what is the mouth pattern or the iris and all, which I'm sure there are a lot of things, but I'm giving you broad principles when you approach a patient of uveitis. Again, with the underline is giving the complete name of uveitis. So telling someone about patient, I'm dealing with a right eye acute non-granulomatous anterior uveitis is way different than just saying that, oh, I'm just dealing with a patient of anterior uveitis. So giving a complete respect to that name, and when you converse with your colleagues or with your consultants, with your fellows, so when you talk on phone, then at least the person in front can imagine what you're talking about. Again, to examine for certain important findings when you look inside the anterior chamber, whether it is hypopyon, nodules, shiny K, corneal involvement, iris translumination defect. There are quite lots and lots of findings which you are there in the book. And I am sure all these findings, all of you can pick up, but putting those together, getting a diagnosis is the key. But the first thing is that you should not miss on any of the findings because every single finding can help you. Important thing in context of uveitis is always to look at a patient as a whole. These are the pictures taken from the articles, not the picture of my patient. But again, when you try to look the patient as a whole, go back from the slit lamp, try to look at the patient face, try to look at the patient as a whole, then you will be able to probably pick up certain more clues to get the diagnosis right. So I often tell a lot of my fellows, you are more like a Sherlock Holmes when you are practicing uveitis. So be like Sherlock Holmes, look at the patient with a suspicious, like trying to find something, so that you should have a scanning eyes, and every time you're trying to find out one little clue, which will help you. So this will be my take-home message, finding out that one extra clue, whether it is from the eye, whether it is from the face, whether it is from the body, that will help you getting an edge over your other colleagues to get the precise diagnosis. So this is again something fundamentally important. There are a lot of publications. I'm not going to get into the details of it, but algorithms which have been published in different journals, and therefore I've picked up through help of Carlos, of course, we picked up some of the articles which is published about how do you approach step by step. Again, here, as you can see in this flow chart, you go with a certain set of investigation. If those are not through, then you go for a second step of investigation. Again, coming from an autoimmunity reviews by another group about an algorithm which they published. How do you go about management? You can go through this. Happy to share the slides with you also afterwards. But again, this will tell you an algorithmic approach about how do you go and approach a patient step ladder. But the idea, and this is by my dear friend from DK Huang from Taiwan. Again, he published a very interesting approach about the expert consensus. Again, something which we fundamentally know, but again, he's published it into paper about the complete history taking, ocular examination, classification of the anatomical location, possible differential diagnosis, and stepwise diagnostic workup. Once again, sometimes you feel like school book teaching, but sometimes it is important to go back to basics, keep these basics in mind, and then accordingly follow a diagnostic pattern for a patient with a uveitis. Again, the take-home message from there, here, all these articles which I've shown in this thing, and is a tailored approach to a patient with a uveitis rather than going with a fixed approach, and more importance to history taking and complete clinical examination and looking for the extra clue is the critical point here. So just to kind of sum up this point number 2 about the precise diagnosis, that the patient with uveitis should include some of the fundamental tests like blood count, acute phase reactant, X-rays, and syphilis screening. And again, personalized medicine is important. And when you put together this test along with the clinical presentation, then can make some sense rather than just relying on PCR or some of the diagnosis. Coming to the management. So these were about the diagnosis based on the history, based on the epidemiological pattern, based on the clinical presentation, and based on certain tests which you can use. Once you have diagnosed a patient with the anterior uveitis, how do you go about managing a patient with the anterior uveitis? What are the broad principles, again, you should remember? Identify the grade of the inflammation. Identify whether you're dealing with just the anterior uveitis or other type of uveitis which might be present. And for that, I'm sure all of you will agree with me that you will have to necessarily examine the fundus and make sure that you're not missing any part of diagnosis. So identifying the grade of inflammation and the related disease. Again, defining a very clear objective, which we miss. In glaucoma colleagues, we should learn from our glaucoma colleagues, they say target IOP, but we don't have a target there. We just treat it. So maybe something for us to consider. Should we set up some target at the beginning of the treatment? That is again something which we at IUSG probably should consider. And what all those target points should consider besides like IOP glaucoma people have, they might have HVF. Probably we should have 3-4 things there in that whenever a person sees, then they should set up a target and then start with the step treatment. Of course, you rule out the infectious etiology as far as possible from your clinical examination. Sometimes it is not so easy. It is easier said than done. And then start with your steroid treatment. Again, based on patient to patient. It will change based on practice to practice pattern. It is changed. But I still remember my school book teaching where I was told that you start the steroids soon enough, frequent enough, and strong enough. So don't be very chicken-hearted in starting the steroid. Oh, I'm not going to give probably just the 3 times or 4 times and all. If you really have to give it. Give it with full confidence that I'm going to give it. Associated with that, supportive therapy of topical mydriatic agent, and sometimes if need be NSAID or other type of drops. Again, I'm not a very heavy user of systemic corticosteroid in patients with anterior uveitis, but very, very rarely in very severe cases it might be needed, though it is written in the presentation. But I am not still will go with this topical steroid unless I see a posterior uveitis component, then I start. But again, case to case basis, we can always decide. Treatment strategy, again, initiate with corticosteroid for control of induction and then continue with that. Calcium, vitamin D, very beautiful article published by Professor Alexandra and the colleagues on the use of vitamin D, and that is they have shown in the systematic review meta-analysis about the vitamin D and its role in the uveitis as such. Now, this controversial topic, I'm not a great believer, I will say, but still, for the completion's sake, I put up when probably we can consider immunomodulatory or probably steroid sparing some of the therapy, where there is a failure to control with the corticosteroid therapy, worsening of the inflammation despite being the patient on the topical and the high-dose steroids if possible. But of course, my first step will be to rule out any other etiology if possible. Failure to control the inflammation, maintain control of inflammation at a certain level. You probably need to consider the case-to-case basis. But once again, this is not commonly used. So don't take it as a take-home message. Dr. Agrawal said it. You need to use immunomodulatory therapy, and then you probably forget about the fundamental thing which has been told. So be careful when you are going to advise immunomodulatory therapy in the patients with that. And I'm sure John will agree with that. He's done quite a lot of extensive work on the immunosuppressive therapy. Just to kind of get back to our track of the last point. So we have covered about epidemiology, we have covered about clinical signs, we have covered about precise diagnosis and about the basic treatment of patient with anti-uveitis. The last point is about the specific etiology, which is coming up in a big way, is the infectious anterior uveitis. So once again, identifying the etiological diagnosis after you have established the anatomical diagnosis should be at the top of the mind. You should try and change it as far as possible, but once again, with the resources at disposal of each clinic and each country and each setting, your approach might change. Some people might not have access to PCR. Then they will say, oh, I'm not going to achieve a complete diagnosis, but I'm sure there are other tricks, other ways to achieve the diagnosis. So though PCR is needed for achieving a diagnosis of CMV and uveitis, but in a resource-limited setting, if you don't have, you can definitely rely on certain clinical signs and see whether you are dealing with a patient with a CMV and uveitis. Always remember in the mind that anterior uveitis, or for that matter, any kind of uveitis, can be a great imitator, and therefore you need to look around the patient, make sure that you are making keep all the possibilities in mind, particularly based on the geographical region. In hypertensive uveitis, that is one of the word of caution. Again, keep a very high index of suspicion for a patient to have an infectious etiology for anterior uveitis. So to conclude, I like to conclude by some of the take-home messages, which I have already said. But once again, dynamic therapeutic objectives, diagnostic etiology should change with the course of the disease. Important point about looking at the patient as a whole, looking at that particular clue, and step treatment, and probably strong enough, soon enough, and probably early enough should be the goal in managing the patient with anterior uveitis. With that, I would like to thank once again IUSG for inviting me to give this talk. Thank you.
Thank you so much, Rupert, for this fantastic conference and very detailed. Very, very nice conference. Thank you again. And now, the first case discussion is non-granulomatous anterior uveitis, presented by Miranda Gerke and discussed by Stefan Thoreau from Germany. So Miranda, please go ahead. Thank you.
So first off, thank you for inviting me. As mentioned, my case is non-granulomatous uveitis. So I'm presenting a patient who's female and 40 years old So obviously, when she first came into our clinic, I asked her what her problems were. And can you see my?
Yes, perfect, Miranda.
Yes, Miranda.
We are
Because
seeing
somehow
your slides.
I cannot. No, sorry, I couldn't get it to run. Okay, so I first asked the patient what his problems were, and she said that she experienced some blurred vision. She had a red eye. She had eye pain. She was very sensitive to light and saw some dark floating spots. Then I obviously asked her which eye was affected. She said that actually both eyes were. And then I asked her for how long this has been going on for. She said for already 1 week. Then I asked her about any underlying conditions, but she said she was otherwise very healthy. I also asked her about her medications, but she said she didn't take any. Then we checked her vision, which was quite decreased on both eyes. It was only 20 to 100, but her eye pressure was normal. Next, I set the patient next to my slit lamp and looked at her eye, where I can see that the conjunctiva was injected. She had a very red eye. And then I looked at the cornea, where I could see some very dusty keratic precipitates all over the cornea. When I looked even further into the eye, into the anterior chamber, I could see some very pronounced fibrin nets and also cells and Tyndall phenomenon, which is actually caused by scattering of light due to protein in the aqueous humor. And the flare and the cells can be actually graded by sun. You would use a slit beam that's 1 millimeter by 1 millimeter and estimate the cells in the slit beam. So for this patient, it's about, I would say, 1 to 2 plus. And then you can also grade the flare in the anterior chamber, which goes from none to a very intense reaction. So from none to plastic almost, with very hazy details. So then I looked to the iris, where I could see that the iris was stuck to the lens. And she has also had posterior synechia that resolved very quickly after applying mydriatic eye drops. After a couple minutes, she only had 2 left. And then after more minutes, there was only 1 left. When I looked at the lens, I could see that pigment was stuck to it still and some fibrin. Then I looked even deeper into the eye, into the vitreous body, where I could see that in the anterior vitreous body, there were some cells and also some haze. When I looked even further into the eye at the retina, I could see, or we did an OCT scan, and we could see a cystoid macular edema. So obviously, we now have the picture of a non-granulomatous uveitis, which we already heard before can be associated with a lot of systemic diseases. So there's HLA-B27 associated diseases. So there's on the one hand spondyloarthritis, but the patient did not report about any joint pain or back pain or morning stiffness. Then there is reactive arthritis. Patient, as I said, didn't have any joint pain, didn't have any cystitis. Then there is juvenile spondylitis and arthritis, but the patient was always healthy as a child, so this is very unlikely. And then there's also chronic inflammatory bowel disease, but the patient didn't report any digestive problems. Then there are HLA-B27 negative diseases. There's on the one hand psoriasis arthritis, but the patient didn't have any skin lesions or any joint pain. Then there's systemic vasculitides, also some sympathetic ophthalmia, but the patient didn't have any trauma or surgery prior to her symptoms. Then there's also collagenoses and also Behçet's disease. But as I said, the patient didn't have any skin lesions, didn't have any ulcers, and had no joint pain. So polyarthritis is also unlikely. Then, as we heard, there's infectious causes. There's bacterial endophthalmitis, which can cause a fibromatous reaction, but patient didn't have any trauma or surgery before, and she's otherwise healthy, so this is very unlikely. Then there is syphilis, which always needs to be excluded, and also Lyme. So depending on the suspected diagnosis, we would do some further diagnostics. So for this patient, since she didn't report about any other symptoms, we checked her for idiopathic anterior uveitis. So we usually always exclude syphilis and check her antibodies. And then we do HLA-B27 and sometimes also check for Lyme antibodies. So this patient was treated by using topical eye drops. We usually use prednisolone acetate eye drops, 1%, and the patient has to apply them in the beginning very frequently, every hour for 3 to 5 days, and then they can reduce it by 1 drop every week. So obviously the patient doesn't need to get up at night every hour, so we usually prescribe them hydrocortisone ointment for the night, and then also some cycloplegic eye drops like atropine 0.5% to take 2 times a day to avoid further posterior synechia. The patient had quite pronounced synechia, but they resolved after I applied topical mydriatic eye drops. If this wouldn't have been the case, we usually use or like to use some subconjunctival injection of atropine and suprarenine or phenylephrine and atropine. What the patient did have was a pronounced macular edema, so we actually used steroids parabobar. We usually give 40 milligrams of triamcinolone alone because it works for about 2 weeks and resolves slowly. So we did this for the patient. So if she would have had a protracted course, which I don't think she had because she never came back, we would use systemic, or we would consider systemic corticosteroids. We would start with 1 milligram per kilogram and then reduce it every week to avoid adrenal insufficiency. So as we already heard, this is not the case with this patient, but if I would have had a patient with a chronic inflammation, a frequent relapses, or an underlying systemic disease, I would consider steroid-sparing immunosuppressants. We like to use methotrexate or mycophenolate because they have a very good benefit-risk profile. However, there's more. There's 10F inhibitors, azathioprine, tacrolimus, interferon alpha, or cyclosporine, which work. This obviously has to be done in cooperation with a rheumatologist because, at least in Germany, this treatment is not approved for anterior uveitis alone. The patient that I presented had a normal intraocular pressure, but if it would have been increased, it obviously needs to be lowered. So we usually start by applying topical eye drops like beta blockers or carbonic anhydrase inhibitors, which also can be given systemic. And then second line prostaglandin derivate, which could increase the risk of a macular edema, and alpha mimetics. So miotic eye drops should be avoided because they can disrupt the aqueous humor barrier and also carry or increase the risk of posterior synechia. So to conclude, diagnosis is made clinically. It may be associated with a lot of systemic diseases, especially the infectious causes, and Lewis must be identified in the beginning because the treatment depends on it. And prognosis is usually good, but complications cannot always be avoided. So thank you for your attention. That's it.
Thank you very much, Miranda, for your nice talk. Now Dr. Stefan Thoreau from Germany will discuss non-granulomatous anterior uveitis. Thank you.
Yes, good morning. Sorry, I'm just need a second to share. I think there's one. You still can't see my slide. Sorry. No, should be better now. Can you see my slide? Not yet. Okay.
Yes, perfect.
Yes, Stefan.
Yes,
Stefan, we see that well. We hear you well. Go on.
Perfect. That's always a nice moment when people say,
Thank you.
"See my slides." I think there is. This image was just taken a few weeks ago, so this is Munich. It's still cold. But now let's go into the discussion of non-granulomatous anterior uveitis. I think there's one thing that's very important, and I will have to stress it again. Making the diagnosis of anterior uveitis can only be done once you have looked at the whole eye, including the posterior pole, and have really looked at the fundus in dilated pupil. Because it's so easy to overlook a few things going on in the back of the eye unless you haven't done it. So the diagnosis of anterior uveitis really is a kind of an exclusion diagnosis that you can only set once you have looked at the fundus, at least once, and you have to do it initially. If the pupil wouldn't dilate because of posterior synechia, okay, I mean, then you're in trouble. But it's very important to keep this in mind. What I want to talk about is more clinical aspects which had not been covered so much in the previous two presentations. One is the HLA-B27 association. The other thing, these are prodromal signs and symptoms the patient has before the clinical onset of uveitis. The third aspect is sidedness, and the fourth aspect is the effect of underlying diseases in non-granulomatous anterior uveitis. The first is B27 associations. Dennis Wakefield, in one of his latest reviews, said about approximately 50% of all patients with acute anterior uveitis are B27 positive. And this is indicative, or this is only true in non-granulomatous anterior uveitis. The moment you have a granulomatous anterior uveitis, this B27 association is gone. The mechanisms of this association are still unknown. So today we would have to call the positivity of B27 just a risk factor. It's not really the cause, at least that's what we believe, but we don't know it for sure. The Sun definition of acute anterior uveitis includes, and this is important to always keep in mind, sudden onset, limited duration of less than 3 months, and in the prolonged course, recurrent relapses, separated by periods of inactivity without treatment for more than 3 months in duration. Very frequently, especially the last part, is a little bit overlooked, but you really have to carefully follow the Sun definitions, because otherwise you tend to group acute anterior uveitis into a wrong category with consequences for the patients. The B27 associations is, actually B27 in the world is changing. So in the Northern Hemisphere, it's much more frequent than in the Southern Hemisphere. Here in Central Europe, for instance, we have around 8 to 10%. And in Africa, or it's around 1%, and in Southern America, about 2%. So these things change. And this is very important when you look at the B27 associations and typing in your region. You have to know the frequency of these alleles. Once again, the testing is only useful in non-granulomatous anterior uveitis. You may have, this is probably not really nice wording I just put here, I'm sorry for that. You may tend to have, for instance, in Central Europe, up to 9% of patients just being positive for HLB27, whether they have anterior uveitis or not, it really doesn't make any difference. So you may have, quote, false positive results if you do testing in a disease or entity of uveitis that's not really associated with B27. Frequently, we see patients with intermediate or posterior uveitis who had been tested for HLA-B27. And then some 10% of these patients will turn out to be positive, and this will have false therapeutic consequences. So please make sure that your HLA-B27 is restricted to those patients and those entities of uveitis that are really associated with HLA-B27. The second aspect is prodromal signs. Now, probably most clinicians, when they have patients who have relapsing diseases, patients come in and says, "Oh, I have this strange feeling in my eye, and it's probably a little conjunctivitis, but I have light sensitivity, photophobia, and a little blurred vision. But when you look carefully with a slit lamp, you don't see anything." Why is that? A number of years ago, we have done experiments in experimental autoimmune uveitis in rats, and looked by intravital fluorescence microscopy into these eyes. What we had done before is injected those rats with GFP positive green fluorescent cells, T cells, which are specific for a peptide of IRBP, the R14, and these cells cause uveitis once you have injected them. It takes a few days, and I'll show you the time course in a few seconds. So these are GFP positive cells. We inject them IV, and we follow the iris with the intravital microscopy. And you can see here in the lower panel that after half an hour, they're sitting, these cells, in the iris tissue, not in the vasculature. They're not flowing in the vessels. They're really sitting in the iris tissue. So within 30 minutes, these activated cells migrate into the tissue. And these number of cells will increase in the iris over time. But it's very early there after the injection. Now, what's happening to uveitis, to anterior uveitis? The clinical score, looking for redness of eye, posterior synechia, fibrin, cells in the anterior chamber, the slit lamp. It takes 3 days before these symptoms come up. before the signs of uveitis come up. So it took 3 days on average in these animals. They have first cells immigrating into the iris tissue, but we can see it only 3 days later. And this kind of prodromal stage is something that the patient feels, because the iris tissue and also the ciliary body are sensitive tissue. There are nerve fibers, there are pain fibers in. And these first days of inflammation, where this inflammatory cell sitting in these tissues, that's something that the patient feels. It's very specific symptoms. It's completely different from foreign body sensation and all these things. It's a very specific feeling. And if the patient has experience with this type of disease and had relapses previously and had these signs, these classical prodromal signs, I always tell these patients, please have your eye drops ready. And when you feel it coming, because it's a very specific sensation, then start treatment already, because you will gain in average 3 days of treatment until we as clinicians finally see inflammation and anterior uveitis in the eye. The third point I want to make is sightedness of relapses. Now, in theory, if you would say, well, it's a diseased acute anterior uveitis that's alternating from one eye to the other, you would expect that of the first attack, the second attack would be with 50% chance the same eye, the third attack, 25% chance at the same eye, the fourth attack, 12.5% chance at the same eye, and so on and so on. But that's actually not what we really see. What we do see is that the first eye that had an anterior uveitis attack will be the leading eye in the subsequent attack. So what you read in the textbook, that's an alternating disease, is only partially true. In individual patients, you will see no alternating disease between the right and the left eye. And we have a number of patients who had 5, 4, 10 attacks only in one eye, and there's still B27 acute anterior types of uveitis. So just keep this in mind. The fourth point I just want to make is in acute anterior uveitis is the role of underlying disease, because underlying disease may modify the course of anterior uveitis. As I just said, and I've shown you this text a few seconds ago, is the SUN definitions is sudden onset, limited duration, recurrent course. Now, this is very true in most cases in who are either HLA-B27 positive or have an ankylosing spondylitis as an underlying disease. And then most frequently, it's one eye at a time. But other diseases like inflammatory bowel disease, reactive arthritis, psoriasis arthritis, these diseases do modify this classical course. The first point, the frequency of HLA-B27 is less, so it's only 15 to 30%, indicating that most of these patients will be B27 negative. There's more frequently both eyes simultaneously affected at the same time. In those patients with these underlying disease, there's more chronicity, indicating that uveitis, anterior uveitis, is more than 3 months. And you have more frequently involvement of the posterior pole, like intermediate uveitis type retinal vasculitis. So just keep in mind that what we usually talk about in acute anterior uveitis is the pure the B27 positive association in patients with ankylosing spondylitis, but that some other diseases may modify the course of the anterior uveitis, and it's still an acute anterior uveitis. Now, these were the 4 points I just wanted to make in addition from a clinical point of view to the presentation that had been done before. And I thank you for your attention. If there are any questions, we can go into discussion.
Thank you so much, Stefan, for your fantastic talk and your practical advice. I don't know if we have no, we have no questions, but I have one question, quick one. How often do you use pupil dilators, and what is your preferred one? And Miranda showed a slide with the the drops used, and how long does it take for synesthesia to stop breaking?
Well, that's a good question. And it's extremely variable. I mean, sometimes, as Miranda showed you, we have, after putting in tropicamide, we see the breaking of posterior synesthesia within a few minutes, within half an hour or so. Yeah. Sometimes you will never achieve it, even if you give atropine and suprarenin and other subconjunctival injections. So this depends very much on the duration and the strength of the synesthesia. As long as it's fresh and the synesthesia consists basically of fibrin, like a glue, then it's fairly easy to break these posterior synesthesia. But once these have secondary become fibrotic, with fibroblast and collagen growing from the iris tissue onto the surface of the lens, then you can't do it anymore. So that's too late. So
yes,
there are two reasons why at each attack we dilate the pupil therapeutically, for basically two reasons. One is see whether we can break posterior synesthesia, at least prevent further posterior synesthesia from development, and that's also one of the reasons why we hate to use pilocarpine, because they
yes,
posterior synesthesia, and we had that. We've seen those cases. And the second aspect is, once you have released the sphincter of the pupillae, some of the pain will go away just by dilating the pupil. You have blurred vision, you have some other problems, but at least the pain will go away. And from then on, it's always very individual. You have to make a decision of how long the pupil has to be kept dilated. Depends, in my hands, predominantly on the existence of fibrin. The more fibrin, the longer you have to use the mydriatics. Now, if we see that we need mydriatics for a long time, we would prefer scopolamine. Sometimes we have to use atropine. At present, in our country, lots of mydriatic agents are not really readily available at the pharmacy. So sometimes you're just happy if we get something that just dilates the pupil and the patient has access to it, because treating as early as possible and as soon as possible really is mandatory. Use whatever you have,
yes.
but the speed is important.
Thank you, Stefan. You have more questions, but we will, to run on time, we will please write the answers in the Q&A. Thank you. Fantastic. So we will continue with our second case. Is anterior uveitis with rise IOP, presented by Armin Takhavi, with a player from Germany leading the discussions. Please, Armin. Thank you.
Thank you very much. Can everyone see my presentation, my slides?
Yes, Armin, they're very clear. Go on.
Thank you. Hello and welcome to everyone listening. First, I want to thank you, IOSG, for the invitation. My name is Armin Tagavi. I'm a resident ophthalmologist at Charité University in Berlin, and it is my pleasure to present a case involving unilateral anterior uveitis with raised IOP that was followed at our uveitis clinic. A 57-year-old male patient was referred by his ophthalmologist due to a unilateral mild anterior chamber reaction in his right eye, alongside a long-standing glaucoma. The patient recorded no subjective complaints. At the time of presentation, he was taking bimatopros and dexamethasone eye drops. There were no recorded eye surgeries previously, and visual acuity used to be similar on both eyes. In our examination, the visual acuity of the right eye was 0.5, and the IOP was elevated to 32 millimeters of mercury. The anterior segment of the right eye showed very few endothelial precipitates and few cells in the anterior chamber. Upon examining the optic nerve head, an increased cup-to-disc ratio was observed. The left eye exhibited no abnormalities in both the interior and posterior segments and showed good visual acuity with normal IOP. Gonioscopy showed a wide open anterior chamber angle in both eyes. The image shows very few endothelial precipitates, which could be easily missed, and a mild corneal edema can be seen here in this image. Due to the abnormalities of the optic nerve head, the patient underwent a papillary OCT, revealing a remarkable decrease in the temporal retinal nerve fiber layer thickness of the right eye, which corresponds to the significant scotoma predominantly in the temporal region of the right eye in the visual field test. So what would be your next diagnostic step? We suspected an infectious etiology and therefore decided to conduct an interior chamber TAP. The analysis of the aqueous humor and the calculation of the antibody index revealed a significant production of CMV antibodies with no evidence of HSV, VZV, or RV antibodies. Thus, our suspicion was confirmed and a diagnosis of a CMV positive Posner-Schlossman syndrome was made. Posner-Schlossman syndrome was first described in 1948 as a so-called glaucomatous-cyclitic crisis. It is assumed that PSS is caused by acute inflammation of the trabecular meshwork, impeding the aqueous humor outflow. Furthermore, the exact cause of the trabeculitis has not been determined, although there is support for an infectious trigger. Most commonly, Posner-Schlossman syndrome is associated with cytomegalovirus, and in some cases in Asia, it is reported to be also linked to rubella viruses. Clinically, PSS is characterized by recurrent episodes of unilateral anterior uveitis. The condition manifests with significantly increased intraocular pressure, an open anterior chamber angle, few endothelial precipitates, and diffuse to sectoral iris atrophy accompanied by a mild anterior chamber reaction. Notably, there are no posterior synechia observed. Ocular hypertension can last from a few hours to 1 month, but rarely over 2 weeks, and the episodes of attacks occur spontaneously without an apparent cause. The therapy of PSS should most importantly target the reduction of the intraocular pressure. Various options are available, including beta blockers, alpha agonists, and carbonic anhydrase inhibitors. Additionally, we treat our patients with antiviral therapy. The goal is to stop or dramatically lessen the recurrence of attacks in CMV-confirmed PSS. However, there had been no established effective protocol for giving these antiviral drugs. Most of the published literature recommends a longer period of antiviral treatment. However, the possible toxic adverse effects of these drugs have to be considered. It should be mentioned that a therapy with prostaglandin analogs may have a pro-inflammatory effect, and the use of cholinergics may increase the blood aqueous barrier permeability and lead to posterior synechia. Thus, these should be avoided. Going back to our patient, we initiated a therapy with valganciclovir with 900 milligrams twice a day for 2 weeks and continued the therapy with 450 milligrams twice a day. Furthermore, the therapy contained the local treatment with dexamethasone and the combination of pressure-lowering eye drops. The patient was subsequently treated by his ophthalmologist. 1 year after valganciclovir therapy, elevated intraocular pressure reoccurred, which could not be controlled under the local therapy. Consequently, we saw an indication for a combined cataract and trabectome surgery. After several months, a discontinuation of the antiviral treatment, a new inflammatory episode occurred with intraocular pressure exceeding 20 millimeters of mercury. Therefore, performing a cyclodestructive procedure was indicated. And since then, under non-preserved local therapy with clonidine and dorsal eye drops, a stable condition with normal IOP has been maintained. There is no evidence that laser trabeculoplasty is useful and thus should be avoided in these patients. In conclusion, Posner-Schlossman syndrome can manifest with a range of symptoms, from being asymptomatic to rarely causing severe pain in patients. It typically manifests with a mild unilateral anterior uveitis, significantly elevated IOP, and potentially subtle recurrences. It has the potential to progress to unilateral open-angle glaucoma. The recommended therapy involves antiviral and pressure-lowering medications. In cases of inadequate pressure control, despite the use of anti-glaucomatous treatment, surgery might be necessary. Thank you very much for your attention.
Thank you, Armin, for your a very detailed and interesting case. We have some questions in the Q&A, so if we can start to write the answers, and at the end we will answer these questions if there is no anyone to be answered. So the third case is a granulomatous uveitis presented by Jonathan Malcolm Shaban and discussed by Ratinam from India.
Hello everyone. Are my slides visible?
Not yet.
Oh. Just a second. Is it
Alejandra, can you understand me?
Pardon me?
It's Uwe. Can you understand me?
Uwe? Yes. Oh, sorry, Uwe.
I had
Sorry,
a connection
Uwe.
problem,
It's Uwe,
but now...
No,
Sorry?
Uwe German will discuss this case, sorry.
okay? Are my slides visible?
No, it's Uwe that will be the presenter now.
Okay, I will stop sharing.
Yeah, now you, Jonathan,
Yes, ma'am.
the slides came first. Yeah.
Okay, Dr. Uwe, I think, will be presenting now.
Okay.
Yeah. So I will share the discussion regarding the presentation from Armin. And I think that the unilateral acute anti-uveitis has to be very suspicious for in infections, but still I think there are differential diagnoses which are important. And the next question is, can we differentiate even by clinical means the different etiologies and of course how to manage these patients? So I think first we have to realize that pressure increase is non-specific, but I would think that in most cases, if you have a unilateral uveitis in the anterior segment, you have to be suspicious regarding viruses, as we just have heard, but also have to keep in mind that also other, in particular granulomatous uveitis types, may also present with increased pressure, in particular toxoplasmosis and tuberculosis, but also sarcoidosis. So I think it's always advisable, as already Stefan has told, that the posterior segment has been always even inspected in these cases. So the most common pathogens that we can expect in the anterior segments are herpes viruses. And here, of course, the alpha herpes viruses, that means HSV and varicella zoster, are the most prominent candidates. And we have to keep in mind that these are persisting in the neural ganglia, whereas the beta viruses, like the cytomegalovirus, is persisting in the myeloid cells, which may have an impact on our treatment modalities and also on the pathophysiology. And also we have to keep in mind that other viruses, like the RNA rubella virus, is a common and frequent cause of increased pressure, and of course very often associated with uveitis. So how can we differentiate, and do we have clinical features that probably have a hint? And of course, KPs are a prominent finding in many of these cases. And if I see a patient which has a diffuse kind of pattern of KPs, also on the upper part of the endothelium, that's very highly suspicious for a Fuchs uveitis, and I think it's a very important clinical finding. On the other hand, the morphology of the precipitates can give a hint, and we do know that granulomatous changes, of course, are more frequent in sarcoidosis, but also in the herpes virus family. So clinical features also on the iris, I think, are very important, and you have to look very carefully by transillumination, since we do know that occlusive vasculitis is a very frequent pathophysiology way that we have ischemia and iris atrophy, even necrosis, as you can see here. And this is certainly a link for a more severe inflammation, which is very frequently linked to varicella zoster virus. And this virus, I think, is underestimated in its clinical importance, since we do have different stages of this disease. The acute stage with this mostly monophasic is short, but afterwards, I think the more severe cases are presenting with vasculitis, with fibrin, hypopyon, even edema can occur, and we have quite often high pressure up to 40 millimeters of mercury in these patients. And this has been respected in the SUN classification, and you can see that here evidence of an anti-uveitis combined, for example, with a sectoral iris atrophy in a patient which is older, probably combined with skin changes, is highly suggestive, of course, for varicella zoster. But we have also to mention that sometimes you don't have the dermatitis, and it can be then more difficult to diagnose these kind of patients. Another, I think, very underestimated problem is that these older patients may have other problems as well. So we do know that the most frequent suicide occasion is happening because of zoster neuralgia. And also the vascular complications are underestimated, since myocardial infarction, for example, is 5 times higher in patients after a zoster ophthalmic. And therefore, I think the cooperation with other specialists is quite important. Also, we have to keep in mind that we as ophthalmologists may increase the risk for these patients. We do know, of course, that the age has an impact, but also our treatment like DMARS or TNF blockers or even JAK kinase inhibitors may increase the risk for zoster 5 times. I think it's very important to keep in mind that these patients probably need a vaccination before we introduce the treatment. So another very important and underestimated diagnosis is certainly Fuchs uveitis, which in Europe at least is probably for up to 2 to 3% of all uveitis patients. And it's very frequently underdiagnosed because it may present not in a complete way. And it's very frequently mistaken as an intermediate uveitis because we do have vitreousase in many of these patients, whereas the index findings, the first finding Fuchs has described, the heterochromia, is only present in about 1/3 of the patients. Therefore, I think we don't have to wait until this presentation may probably occur. And here again, we do have the SUN classification for Fuchs uveitis syndrome. I don't like the expression actually, and I don't like actually the criteria, since it may present even bilateral in 10%. And what we can find seems to be an infectious disease, since in almost all patients that we see in Germany, at least, we can find rubella virus antibody synthesis in the aqueous humor. And therefore, I consider this entity not really as a syndrome, but this can be discussed. So anyhow, in any case, when we do have an unclear etiology on any kind of suspicious on viruses, I think the best way is to really confirm your research. Therefore, PCR, the Goldman-Whitmer coefficient,
there are problems with Uwe's connection because he's in Vietnam, so probably we will wait for 2 minutes, and then if not, we will start with the other speaker. But I think Uwe is having trouble with the connection.
So Alejandro, we can move on with the next presentation then.
Okay, so at the end we will see.
I think
no,
he's
Uwe,
back.
great, great.
I'm sorry. And the conclusion certainly is that we do have an increased IOP and anti-uveitis.
Sir, sorry to interrupt you. Can you please share your screen once again, please?
I'm through. I'm sorry. Can you hear me?
Yes, but can you share again your slides, Uwe, please?
I dropped out. I think I have just 2 more. I'm sorry.
Don't worry about that. We know you are.
So I guess we can go here. Can you see now?
Okay. Yes. Yes.
Yeah.
That's perfect. Thank you.
So just in conclusion, as Armin has showed, Posner-Schlossmann syndrome is not a benign uveitis entity, since it has a risk of relapses and progression. And I think this is the case in all of the viral entities that I have presented, and in particular in the older patients and in the immunocompromised patients. I think it's a problem that we have to keep the patient on the longer term treatment. I think this is a point that we probably have to discuss. And it's very helpful to have an anterior chamber tab to verify your suspected diagnosis. Thank you. Sorry for some kind of technical problems at the end.
Don't worry about that. We know that you are in Vietnam and you are doing an effort to be here with us. So thank you, Uwe, for your great talk. And now, granulomatous uveitis, presented by Jonathan Malcolm and discussed by Dr. Ratinan from India. Thank you, Uwe. Thank you so much.
Are my slides visible?
Yes, yes.
Yes.
You have to slide share.
Yes, yes, ma'am.
Good.
Yes. Hello, everyone. I'm Dr. Jonathan, and I'll be presenting on granulomatous anterior uveitis. So, a 42-year-old female first presented to us with left eye pain and redness for the last 1 month. The pain was insidious in onset and gradually progressive with persistent redness, but she did not take any treatment for it. On further probing into the history, she said that 1 month prior to the onset of her ocular symptoms, she had a urinary tract infection for which she took an antibiotic prescribed by her physician. Following the intake of the antibiotic, she developed a skin rash, which she then went to a dermatologist who prescribed an ointment, and then it resolved. So on ocular examination, her right eye best corrected visual acuity was 6/6. In the left eye, it was 6/9. On a slit lamp examination, there was a circumcorneal congestion. On the cornea, there were granulomatous keratic precipitates. I'm sorry, it's not very clear in the image here. In the anterior chamber, there were 1+ cells and 1+ flare. The iris showed a sort of different looking iris atrophy, which had transillumination defects noted on retroillumination. Fundus was normal in both eyes with normal optic discs. Her intraocular pressure was, when measured with applanation tonometer, was 12 in the right eye and 38 in the left eye. On gonioscopy, both angles were open, but in the left eye, we noted a peripheral anterior synicate in the inferior quadrant. So on our investigations, we found that the white blood cell count was elevated to about 18,600 and her ESR was 62. Rest investigations were normal. So we had two differential diagnoses in mind. Our first one was viral anterior uveitis because it was unilateral. There was elevated IOP. There were presence of granulomatous keratic precipitates, and there was iris atrophy with transillumination defects. But what was going against viral anterior uveitis is that she did not give history of rash along a dermatome. There was no keratitis. Corneal sensations were intact on examination, and there were presence of synicate, which is not usually seen in a viral uveitis. Therefore, we considered, could there be another cause of the uveitis, which we thought could be a drug-induced uveitis or maybe caused by a fluoroquinolone, because in India, for urinary tract infections, we usually give fluoroquinolones like norfloxacin or levofloxacin. So literature shows that fluoroquinolones can induce uveitis, and they do have a history of causing a phototoxic dermatitis after intake. They can also cause pigment dispersion, which can present with iris atrophy with transillumination defects. Synicate are present. However, points which were against the drug-induced uveitis was it was unilateral, where the only known case of a unilateral moxifloxacin-induced uveitis was when it was given intracamerally for prophylaxis of post-surgical endophthalmitis. Another point against the drug-induced uveitis was that the inflammation was persisting even after stopping the antibiotic. So, keeping an infective etiology in mind first, we treated with oral valcyclovir with topical steroids and anti-glaucoma medication to control the IOP. Patient then said that she felt better and she came to us 1 year later. When she came 1 year later, she said that she went to a local hospital which would just treat the inflammation with topical steroids, and they were also suspecting a viral etiology, so they would give oral valcyclovir. However, the inflammation would recur and IOP would be continuously elevated. She does say that she was not well compliant to oral valcyclovir due to financial constraints. And when we checked the vision, it had now dropped from 6.9 to 6.24. So now on slit lamp examination, we saw that there was a posterior subcapsular cataract. And because of the persistent elevated IOP, the left eye had progressed to glaucomatous optic atrophy. The intraocular pressure was 10 in the right eye now and still 36 in the left eye. So we did an AC tap this time, which unfortunately did come negative for viruses. To relieve the pupillary block that was causing the elevated intraocular pressure, we did a lag laser peripheral iridectomy and we restarted valcyclovir. This is because drug-induced uveitis we can now definitely rule out, as it has been a year with persistent inflammation. So we started maximal medical therapy for IOP control, restarted topical and oral steroids, and we also started topical ganciclovir ointment. When the inflammation came under control, we took up for phacoemulsification and trabeculectomy. And at her final visit, the inflammation and IOP were well controlled. So I would now like to open for discussion whether we could have considered an alternate diagnosis or an alternate line of management. Thank you.
Thank you, Jonathan.
Thank you.
Very well done.
Thank you.
Thank you so much, Jonathan.
Thank
And
you.
then, fantastic talk. So, and then Dr. Ratinam, please go ahead with your discussion of this case.
Yeah, actually the previous case was presented. Am I audible? Am I audible?
Yes,
Yes,
but
Dr.
My slides are visible?
No.
No.
1 second.
Okay.
1 second. Is it visible now?
Yes, now they are
Yes.
visible. Thank you, Dr. Ratina. Go
Thank
ahead.
you. Thank you. The reason we presented that case was such a peculiar iris atrophy, and viral PCR, RT-PCR were negative. However, we don't have any answer. Probably metagenomic study would have showed us some new virus. So we wanted to present the diagnostic challenge, but granulomatous uveitis is so many types, so many etiologies, and it is very, very important to touch upon at least common etiologies. To come to the commonest ones, tuberculosis, very, very important, sarcoidosis, followed by traumatic, fungal, and parasitic. So there are quite a lot of granulomatous uveitis, but this is anterior. So I am not touching the pan-granulomatous uveitis, just anterior granulomatous uveitis of other causes other than virus. So whenever we see such a granuloma and hypopyon, it is 99% we suspect tubercular, and we could immediately do as anterior chamber tap, and we stain for tubercular bacilli. And in this case, patient also had lung involvement. So this is a very typical tubercular granuloma in the anterior chamber. I in fact had at least 5 or 6. Due to time constraint, I'm showing just one granuloma. So now we move on to the second cause, sarcoidosis. So this is also a granulomatous uveitis, either unilateral or bilateral, and many times we may have some lymph nodes enlarged, which can be biopsied and proved. So tuberculosis and sarcoidosis is very, very important. Then, in fact, acute bacterial syphilis also we have to consider, even though it is very rare. So chronic bacterial tubercular, acute bacterial syphilis, and autoimmune cause sarcoidosis. And now coming to the fungal. Invariably, this is followed by a trauma, and any fungus you can see. In this case, it is cladosporium, but we can have at least 5 or 6 very, very common fungus that is seen in villages and very commonly seen in diabetic patients and also in agricultural workers, because they are prone for trauma. And every time, whenever we aspirate, we do come across with some surprise, some funny virus. Very difficult to treat, but now we are coming to the parasitic etiology, which is very recent onset. We have recently found out this. You can see in the picture that it is a solitary granuloma in the anterior segment. What happened a few 2 decades back, there was a South Indian village, and from the village, there are 4 children with similar granulomas. It was very surprising to see 4 children with granuloma, because tuberculosis will not occur such a big epidemic. And when I was talking to the patient was very proud to say that we have more than 30 to 40 children with the same eye disease. So it was very surprising to us. And when we asked the further history, they told whenever they take bath in the pond, when they swim for a long time, they get red eye, and those people get the eye disease also. It was very, very positive history of exposure. So we went to the village and we collected all these boys, and we took them for surgery and aspiration of these granulomas. And we took 40 samples, 40 granulomas. And you all know our mentor, Dr. Narsingh Rao. I handed over paraffin blocks of 40 samples, and surprisingly, 3 samples showed evidence of trematode particles. So, but there is no way we can prove because it is a cut section. We cannot see the morphology of the worm. So we published this as a presumed trematode granuloma. This also occurs in association with subconjunctival granuloma and Calaisian-like lesions and anterior chamber granulomas. And so initial clinical picture with the presumed diagnosis was published as early as 2001 and 2002. And the intermediate host is snails. So this is exactly like schistosomiasis. In India, all these patients were treated as tuberculosis some 30 years back. All these patients were put on TB because it is like tubercular granuloma. But at least our study showed that it is not TB. So we started asking the doctors not to start TB treatment. We further wanted to prove the etiological factor. And only way is molecular diagnostic. So we collected the snails from the pond and we collected these larvae. It is very easy when you put it in a petri dish and give the enough light. All these larvae will come out swimming in the petri dish water. So we collected DNA from the larva as well as from the granuloma, and we did sequencing. We did initially RT-PCR. We collected the DNA and then we did sequencing and blast analysis, and that proved as the trematode. Trematode disease, you all know schistosomiasis is very common in Africa and South America and Southeast Asian countries. And similarly, we have flatworm trematode infection in the eye. We were able to pinpoint the cause as procervum, this species in our area. Later, we published in Archives of Ophthalmology about the etiology and also in emerging infectious disease. This is important to be presented in International UVEITIS study group because this disease is not only seen in South India. This is seen in Brazil, Egypt, Madagascar, and Sri Lanka, and several Southeast Asian islands. So this has international implication. Now several papers have been published from these countries after our research work. And many countries thought it is a fungal lesion. Some of them thought as tubercular lesion. And the treatment is only aspiration of the granuloma. So thank you for giving me this opportunity.
Thank you so much, Dr. Ratinan, for this fantastic and very, very interesting case. We have an active Q&A and also a very good time for discussion. So I saw that Dr. Uwe Player would like to answer some questions live.
Yeah, one question was regarding the treatment course in CMV positive anterior uveitis, and I have to say there's no agreement first to treat systemically what we do, since in Asia there's also an ointment available which is 2%, and it has been reported some patients may react positively. That means they respond to the inflammation when you apply topically ganciclovir as an ointment. I have to say, first, we don't have it available. And second, it's very difficult to have a 2% solution. Our pharmacists have been not able to repeat this kind of treatment. And at 1.5%, that's the maximum that you can reach. But what we are doing, we are treat the patient systemically, and we start with 2 times 900 milligrams for 2 weeks, and then we continue the treatment. And again, as I mentioned, there is no really agreement how long you keep the patient on treatment. We do at least 6 months. And there have been one study, I think, from Tübingen, where most of the patients have been kept on 2 years, which is, I think, very costly. That's certainly a concern that we have to keep in mind. And also, valganciclovir is not as, let's say, safe as acyclovir. So we have to keep in mind that also leukocytes may go down. You may have a leukopenia in the long-term treatment. Therefore, I think to keep the patient on a safe, stable side regarding recurrences, and the treatment effect should be, of course, be seen in these patients. But how long, again, nobody can, I would think, tell how long we can keep and should keep the patient on ganciclovir. But maybe other people has other experience and certainly a point to discuss.
Yeah, I do agree with you. It is very difficult to stop, and a drug is very expensive. The moment we stop, it comes back again. It's very difficult.
Yeah, we have some patients even begging for the longer treatment, and if they tolerate it very well, and it's a single eye patient, there are always occasions where you have to keep an individual perspective on the patient, and some won't like to stop. I think it's not indefinitely, but up to 2 years, I would think it's not a big problem if the costs are not a concern. How's your experience with topical treatment? I mean, we are not happy with topical treatment, but what I realize is that if you do a quantitative PCR, you may have a kind of an idea if it's a low load of viral replicants, maybe the topical treatment is sufficient. Unfortunately, again, we don't have it available, but it might be an option. And I think an important point is also that the CMV has a more deleterious effect on the corneal endothelium. So we did a study and we could see that the other eyes and non-affected eye had significantly higher endothelial cell count. And if you have to do surgery, which is of course in these older patients quite often, it might be that you may run in problems if you don't really observe carefully the endothelium of these patients. So I would advise in the affected eye, if you do glaucoma surgery or if you do cataract surgery, to do first an endothelial cell count, since it might be a limit below 800 cells per square millimeter. And it's another finding which is different from HSV and varicella zoster, where you don't have such a strong impact on the corneal endothelium. So there seems to be a more endothelial problem anyhow, not only on the vasculature, but also on the corneal endothelium.
Thank you, Uwe. So Vishali.
Yeah, to add to CMV anterior uveitis, as Uwe is mentioning, the endothelium is affected. So I find doing a specular microscopic count very useful. And if you have a unilateral disease, you will invariably see a reduced count in the affected eye compared to the normal eye. Also, if you have confocal and you can look at the owl-like inclusions, like many of the questions was regarding, like if PCR is negative, what do we do? But if your clinical picture is very characteristic, you have reduced count on specular. Confocal is very rarely positive, but if you find it, these are the very important clues towards CMV. And in my experience, topical works well along with anti-glaucoma and steroids. And we did the Titan study where we did find that there was a variation amongst the experts regarding the duration of the therapy. Asia is the region where CMV is seen more commonly, and studies from Sunfik and group have shown that topical is the first line of therapy for them, ganciclovir, topical gel, and I use it all the time. And I actually monitor my specular count as one of the measures of response to topical therapy. The oral is added in cases with recurrent, and in Europe, most of the experts would treat it for 2 years. So was the case in Asia Pacific, but our colleagues from US would give it for 6 months. So there are a lot of questions, but I think we do not have the clear-cut answer yet. But as Uwe said, it will depend on patient's response, monitoring, and how the patient behaves when you want to stop it, you know.
Dr. Vishali and the others, the iris atrophy which Dr. Jonathan showed is so funny and peculiar. Have you seen such iris atrophy?
I have seen this in a case of Badi, like Ilknur used to show us those beautiful cases of Bate and Badi and fluoroquinolone. So I had this patient who had undergone LASIK surgery. And following the LASIK surgery, the patient continued to have some of these pigment and they kept on treating with fluoroquinolone. So long-term use of fluoroquinolones and the bilateral iris atrophy, both in Bate and Badi, can be like this.
But in this case, it was unilateral, and the recurrence after 1 year, they didn't have
Yeah,
fluoroquinolone
that is the
treatment.
point. Yeah,
That
that's
is
the point against. Yeah.
And this AC granuloma, probably the audience from Africa can also see whether they have similar cases. Because the countries along the equator has the disease.
I don't have any cases like that in Addis Ababa, but it's not really a tropical area because the altitude is so high. But you certainly keep your eyes open for that.
I have a question for the first case. Maybe Stefan can answer. The first case had non-granulomatous anterior uveitis with cystoid macular edema. So my question to in fact all the panelists is, how often do you do a fluorescein angiography when you see cystoid macular edema, or you just treat with depot steroids or Subtenon or just topicals, or do you? What's your next line of action?
When it is fibrinous reaction, probably OCT will do. But when there is vasculitis and cystoid macular edema, FFA, we opt for.
Okay.
Usually in anterior uveitis, you do not do fluorescein angiography. If you would do fluorescein angiography in anterior uveitis, especially wide field fluorescein angiography, you would see leakage in the periphery, but it really doesn't indicate that there's a posterior segment involvement. So look at the cells. I mean, if you have some cells in the anterior vitreous, then it's just a spillover. If you have cells in the posterior vitreous, or even more cells in the vitreous than the anterior chamber, then you probably have to rethink your diagnosis, whether it is an anterior uveitis, and do a fluorescein anyway. But just if you have typical signs of anterior uveitis, the cystoid macular edema is a complication. It's not an own disease entity. It's just a complication. And in general, we do not use fluorescein just for seeing the cystoid macular edema. If you do, we've done it in the single cases, and then you see a little leakage, but it really doesn't make a difference. It still is an anterior uveitis, looking at the cells and comparing anterior chamber versus vitreous. So this would not be our common approach. Any other comments, or are people doing it somewhere in other cases differently? The reason for me being a little reluctant with fluorescein angiography is it's an invasive diagnostic, and you sometimes may have allergic responses. So fluorescein angiography is something where you really should have a good reason to do.
Yes, and we have also the possibility to make a non-invasive test such as OCT. So
Yes.
probably it's better if you suspect a cystoid macular edema clinically, you can perform OCT.
And that's what you usually do.
Exactly.
I think in cases of anterior uveitis with loss of vision or reduced visual acuity, doing the OCT is almost mandatory because mild macular edema are just not really easily be seen clinically, not with a 90 or a 78 or whatever diopter lens. So in a way, you really have to do, because cystoid macular edema also always is a good reason to intensify treatment, because cystoid macula really requires treatment. There's no excuse. So OCT is the issue.
Exactly. Mhm. We have some interesting questions, and I know that some of them are just answered, but it would be interesting to also comment about some of these questions. One of these is in cases. Oh no! One of these, Ilknur asked, I don't know if there is any triggering factors. We do see more acute anterior uveitis relapses in early spring, but the role of season is unclear. So do you think is any seasonal variation in anterior uveitis? And the other question was about the trauma, if it's a trigger for anterior uveitis in HLA-B27 patients. What do you think about that?
Well, the answer with the seasonal stuff, that was my answer to the question. Yeah, so we do see it. We do see it sometimes. Statistically it's a mild effect. So maybe there is some seasonal influence. I think statistically there is, but I really can't give you an answer as to why is that the case. What are the mechanisms behind it? We really don't know.
There is a question addressed to me. Dr. Aman is asking, do we have any systemic parasitic treatment? No, there is no systemic parasitic treatment because it is a dead parasite, dead larva in the anterior chamber. So we have to only surgically remove this. There is no medical treatment. Hope I have answered.
Yeah.
Alejandra? Yeah.
There is another interesting question, and it's about the role of using topical non-steroids anti-inflammatory drops to reduce the rate of recurrences in HLA-B27 anterior uveitis.
Again, probably I think I would have to comment on this. I know many use it. My personal experience with non-steroidal anti-inflammatory drugs as topical treatment for preventing recurrences are pretty poor, so I just don't do it. I prefer to use steroids, preferably prednisolone acetate, giving the patients once a day, 3 times a week, 2 times a week. I even have some children in whom who have 2 drops a week or just 1 drop a week and are quiet, and when they go on holidays and forget, they suddenly come back with a relapse. So I personally prefer steroids, and I'm not really very happy about the use of non-steroidal anti-inflammatory drugs. By the way, if you use it more frequently, there are some disturbances to the ocular surface, especially the corneal epithelium. But I know that I always realize and see that other people use it and seem to have different experience. So probably someone here from the panel can comment on it, please.
I agree with Stefan, and he's already typed. Giving a long-term prophylactic non-steroidals have not shown in literature any evidence to prove that they will reduce recurrences. So we do not have the evidence in literature to recommend its use.
That would fit my experience.
So I have a point to make regarding Postner-Schlossman syndrome. I don't know if any of you has seen any of these patients presenting later on with retinal necrosis, because I have a patient who presented with Postner-Schlossman syndrome in 2018. And on follow-up, she came in 2022 with an acute retinal necrosis in the same eye.
I have seen PS syndrome earlier, coming back with ARN after years.
Yeah. So
it shows that we have a persistence of the virus maybe in the leukocytes and then probably reaching the posterior part of the eye and maybe causing even ERNR. Which is rare. I mean, acute retinal necrosis, was the patient immunosufficient or did he have any kind of immunosuppressive?
Systemic comorbidities. And that also says that probably it's not only the CNV, probably it is the HSV or the VZV, which is in the eye. So, most of the time we relate CMV with Postner-Schlossman, but I think it is the other way around also.
Yeah.
Well, I think the problem is that all these viruses persist. Yeah, even if you successfully treat, you'll never get rid of them. So whether they pop up again as in chronic anterior uveitis or may, for a reason we do not know, suddenly affect the retina and lead to retinal necrosis or retinitis. I mean, this may happen, but I think it's rare. I think I just. If I think back, I can recall one patient whom I had.
Secondary infection.
The other possibly mechanism could be that some other infections, that some other diseases may lead to a short-term type of immunosuppression or long-term immunosuppression, and then which we do not detect clinically. But I mean, honestly, all these things are just speculation.
And we also have to keep in mind that the older patients have these kind of immunosenescence. So the response, we know this also from toxo and for other infections, that the clinical course can be quite different in a patient over, let's say, 50 or 60 years. And many of these patients may respond in a different way and present otherwise. And I'm not sure whether I have given the answer to the anterior chamber tab, since I have a problem with technique, I'm sorry. So what I wanted to explain is that we are using mainly the Whitmer-Goldman coefficient, which seems to be also in the viruses a bit more reliable, let's say, since the patient may have just a very few days, even a shorter time, appearance of the virus in the anterior chamber, and this may disappear quite soon. And the persistence of the antibodies is probably, in this case, a better way to detect the responsible agent. And if you can do both PCR as well as anterior chamber antibody synthesis, I think that's the best way to detect any of the organisms. The same is true also for toxo or for other organisms that you may miss if you do just once a tap and your PCR is negative. That's my personal experience, and I think the Dutch group also has shown this difference between PCR and antibody synthesis, which is difficult to get. So it seems to be that you need your own lab to do this, since it's not commercially usually available and not so frequently done in the infectiology labs. At some point to discuss maybe also.
I agree, Uwe. We are using Goldman-Whitmer coefficient more and more at the beginning for research, but now we are starting to do it because it's very useful, and because one of the concepts we are trying to convey here is that the PCR, if the PCR is negative, we should not rule out the infection disease, because sometimes I see that colleagues send the sample for PCR, and then when it's negative, they say, okay, it's not viral, okay, it's not an infection, but this is not the way to do it. So we have to make an empirical treatment and see how the patient responds. But the thing is that PCR positive confirm 100% confirm the diagnosis, but if this is negative, we cannot rule it out. The clinical is the main or the most important thing. And I have a question. When you have a patient with under treatment with antiviral therapies, how often do you ask for liver or renal function? Because I have some patients with really bad problems in renal function with, for example, valganciclovir. Here is super expensive, and then also we are experiencing problems with renal function troubles.
I think at the beginning you have to have a basic value on creatinine on the clearance, and if the patient is healthy, I mean this still is the case in many patients, I would do the first test after 4 to 6 weeks, and then I follow the patient in, let's say, 2 or 3 months. And it's sometimes difficult to get the results, so sometimes we do it ourselves in the clinic just to be sure that it has been done. Then sometimes the patient even does not care, doesn't go to the general practitioner, and therefore I think to be on the safe side, I would do this since I think it's important. It's not the kidney function, it's more the leukopenia which may have a problem. And we had 2 patients out of, let's say, 60 CMV positive Boston-Schlossmann, which had a problem with decrease on the leukocytes, which was not critical in any of these patients, but still you could see it was not a normal count. And then we have to be careful. And luckily, then we could stop the treatment anyhow. So it was not a problem. And the leukocytes recovered. So it's not a persistent problem. And I mean, even in acyclovir, you have to adapt the dosage on the kidney function.
Exactly.
At the beginning. And if it's an older patient, I early would check and see how the clearance and creatinine in these patients might be. And you have to adapt your dosage. So if it is already compromised, then you have to lower your dosage, which you can do easily if you do it IV in acute retinal necrosis. But in the long term, of course, you can also adapt your oral treatment in these patients in response to the kidney function.
Thank you, Uwe. And do you take the anterior chamber tap before starting the medication? Because the performance of the results of the PCR positive are lower when the patient starts the medication.
We do the anterior chamber tap and the Goldman-Whitmer in our patients. So that's
yes, but before starting the medication, or
no, I mean, if I'm sure clinically that the patient has, if it's acute retinal necrosis, of course, there's no question about this.
No, yes, in acute retinal necrosis, not that.
But even in the anterior chamber, let's say the anterior uveitis case, if I'm clinically sure, then I would start the treatment
right away.
Yeah.
Okay, perfect.
Thank you. I think time to wind up.
Okay. Please, thank you.
Thank you, everyone, especially Alejandra, for this. So if I can conclude what we heard from our amazing speakers, that first was the case shown of a non-granulomatous anterior uveitis. So you look for the simple clues, fibrin, acute attack, and Stephen showed it beautifully that many a times the patient will have prodrome. They come to you with a feeling that something is not right. You may not see cells on the slit lamp, but if you do UVM, actually your ciliary body will be swollen. Everybody doesn't do UVM. There is no need. Just ask the patient to carry their topical steroids with them. and start using it. Stephen beautifully showed the HLA-B27 versus non-HLA-B27 and what could be the differences. But I do understand that many of our colleagues are from the countries where HLA-B27 may not be done routinely. It's not really required to make the diagnosis. Even if you cannot do, it's okay. The treatment essentially remains the same. Topicals are the mainstay, and we add, the immunosuppression very, very rarely. But again, Stephen said a beautiful point that you have to know that it is only anterior uveitis by ruling out the posterior segment involvement. Because the equation of giving immunosuppression, biologic, systemic treatment will change the moment anterior uveitis is not standalone and it's a part of the posterior or panuveitis. Now, coming to the question of the viral anterior uveitis, I think Ube discussed it beautifully, and the most of the questions were directed towards management of viral anterior uveitis, and Alejandra took it up very nicely, the discussion. The bottom line still remains the majority of the questions were about qualitative versus quantitative PCR. In Titan group, we did show that our experts do not repeat the AC tabs to see whether the titer is reducing or not. You rely on the clinical clues. Your IOP going down, anterior segment inflammation decreasing, and if you have the specular, the endothelial count getting reversed. You do not really have to tap. The second question which people were, like a lot of our friends were asking is, like, is it okay to give steroids even if it is viral? It's a very slow growing CMV, and if you see uveitis, you are not sure it's viral or not, you can start with treatment empirically also if you do not have the facilities to do PCR. Because in the real world, many of our colleagues may not actually have access to PCR. So if you suspect it clinically, start it. If it's not responding, then we go on to, further investigations. Drug-induced uveitis is not common, but Dr. Ratinam beautifully showed the various etiologies that granulomatous uveitis can cause. And as has been seen, granulomatous is likely to be more infective than non-granulomatous. And in the end, just one point, these are all for adult anterior uveitis, and Alejandra has planned a separate session for pediatric because the same etiologies may not apply to pediatric or even geriatric population. So we will address them separately, and these are the general age group that we are, addressing in this question. So, one last question to all panelists. I'm going to invite one by one, all of you, to give a take-home message to our attendees, just one-liner or two-liners for anterior uveitis. So we start with Ube Claire.
So what I would do regarding the impression of any kind of infection is to subtly look to your slit lamp and observe the findings that you may detect. I mean, it's sometimes easy to identify, let's say, for example, a patient with Fuchs uveitis, and it's very important not to overtreat this, not to treat even these patients. So I think it's another very important message. These patients are not so rare. And if you have clues for a viral infection, I think even if you don't have access to the more sophisticated techniques like PCR, you can probably rely in a single eye patient with IOP increase that it might be a herpes type virus, and you may treat the patient adequately regarding antiviral treatment and lowering the eye pressure. And if it's response, you may see this as a positive finding that confirms your diagnosis.
Stefan?
Well, non-granulomatous anterior uveitis is basically the other side of the coin. Make the diagnosis, treat early, hit hard, dilate the pupil, look at the fundus to exclude posterior segment involvement or not to oversee any posterior segment uveitis. Think of the prodromal states that will help in experienced patients to tailor the treatment, optimize the treatment. The other important issue is that we just touched briefly is treat effectively cystoid macular edema and non-granulomatous anterior uveitis, and explain to the patient that this thing might be relapsing, and the relapse is maybe 2 or 3 times a year and may take another 25 years before the next relapse comes. So it's extremely variable. Thank you.
As you correctly mentioned, granulomatous uveitis is often infectious. So we have to be very careful, especially when it is unilateral anterior. We have to be very, very cautious, because the other non-infectious like VK syndrome, sympathetic ophthalmia, sarcoidosis, they are autoimmune. So when we make a mistake between sympathetic ophthalmia and VKH and sarcoid, just by giving steroid, we may not harm the patient. But a fungal granuloma in the eye should never be treated with topical and oral steroid. As Vishali Gupta mentioned, we have to be cautious about infectious causes. Thank you, Vishali.
Thank you. Rima?
So I think especially in unilateral anterior uveitis, I would always pay attention to the fellow eye, because many times we get clues from the fellow eye, and especially non-granulomatous anterior uveitis, patients of HLA-B27. So although they're symptomatic in one eye, sometimes they have those pigment rings on the anterior lens surface in the other eye. And also while it's mandatory to dilate the affected eye with anterior uveitis, we may also get some clues from the fellow eye dilated fundus examination, like, old vasculitis or chororetinal scars or anything of that sort. So
John? So John doesn't seem to be there. Last comment from Alejandra, who has masterminded the whole event. Yes, Alejandra.
Yes, so one of the important things here is that the optimal therapy in anterior uveitis depends on the cause, severity, and the associated systemic disease. And topical and systemic steroids should be used enough, soon enough, often enough, and long enough to secure the desired results. And we should monitor in response to treatment. It is essential. And anterior uveitis should be also referred early to the uveitis specialist, because sometimes it's like, no, it's not a posterior or panuveitis, so you should refer always to the uveitis specialist. I have a comment, for a quick answer for all of you. And if you, sometimes we see colleagues prescribing dexamethasone and fluoromethalone instead of prednisolone, where there is hypertensive anterior uveitis of viral origin. What is your opinion about this?
Uwe, one last question. Would you give or not fluoromethalone instead of Dexa?
No, fluoromethalone doesn't penetrate, so I think this is not making sense.
So
but prednisolone or even dexamethasone higher concentration will reach, and it's important since the anti-inflammatory treatment will also lower the pressure, since it has an effect on trabeculitis, and therefore I think it's necessary in many cases.
Absolutely agree, because sometimes we see fluoromethalone or dexamethasone and not predni because there is a very high pressure. But we should put the patient under predni.
Thank you.
And keep in mind that it takes time to higher the pressure. The pressure doesn't go up within 3 days, so the response takes at least a week. So if you have a high pressure and are suspicious that it's probably drug-induced, it takes some time. So it does not immediately go up.
You know, I always ask my patients to dig out the first episode when they presented. If the pressure was sometimes you recorded at the first time, but over a period of time it becomes drug-induced, you know. So that is a very important step. I would like to thank Miranda, Armin, and Jonathan on behalf of all of us from IUSG for doing such a wonderful job and presenting great cases. Before I pass on to John to say the last words, on behalf of IUSG, I would like to thank you all for attending the webinar. Please write your comments. This is a new series we have started, and we would like to make changes, modify it, customize it as per your comments and suggestions. So I always read all the comments you people write. So before sending, please send this so that we can modify. And our next same grand round in the series would be on 10th of February, which will be on intermediate uveitis. And hopefully Alejandra and team is going to compile up all these cases as IUSG Grand Round resource, which will be available to you with all the discussion synthesis. Over to you, John, to conclude.
You are muted.
John, you are muted. Yeah.
We cannot hear you, John.
Yes. I think we are not
I'd like to
able
thank Alejandro in particular for arranging this beautiful session as sort of the leader of this session and the editor of the eventual book, and also Rima as secretary of the education committee. So thank you so much, and we really appreciate everyone calling, and I'm sorry I'm having some technical difficulties, but thank you. It was a beautiful session and a great start to our Grand Round series. Thank you.
Thank you. Thank you, everyone.
Thank you so much.
And see you on 10th
Great
of February.
session. Thank you so much to all of the
Rima,
participants.
Rima, there is Rima, please answer the question. There is one question which you can answer very well. Q&A. You can just type the answer.
I can't find the question.
It's in Q&A.
But it's
okay.
showing.
Somebody's answered. Okay, perfect. Okay, thank you.
Thank you.
Bye.
Goodbye.
Thank you.
Goodbye.
Bye.
Have a nice weekend.
Thank you so much.